So Lucy, Priscilla and I have split our talk up into three sections. I'm going to start off, I'll just see if I can get the slides to move, by talking at a very high level about what endometriosis is. I'm then going to hand over to Priscilla, who's going to talk about the diagnosis journey, and then Lucy's going to finish and tell us about pain management. So first of all, what is endometriosis? Well, it's a remarkably common condition. It's said to affect 1 in 10 women. That's the equivalent of 1.5 million within the UK, 190 million women across the globe. So it's incredibly common. You probably, if you're not a sufferer of endometriosis, you probably know someone with endometriosis, sadly. And endometriosis is defined by the presence of tissue like the lining of the womb outside of the womb. And it can appear anywhere in the body, but the most common place is this within the pelvis itself. And the most common type of disease that we see is called peritoneal or superficial disease, which is shown up in this top left-hand panel, panel number 1. And what you see is these often these bluish grey sort of powder burn type lesions on the wall of the pelvis, as shown by this image taken during surgery. Another type of endometriosis that we see is deep disease or infiltrating disease, and this is a disease that forms nodules, often involving the bowel and the bladder. And you can see a nodule here just behind the uterus in the left-hand picture, and it's also showing up on this MRI scan here. And then another subtype of endometriosis that we see is ovarian disease, the so-called endometrioma, cysts that form on the ovaries. And these cysts are characteristically filled with altered blood, which shows up as this sort of brown colour, as you can see here, or shows up as what we call a ground glass appearance on an ultrasound scan shown in this image in the bottom corner. But of course, endometriosis is much more than the lesions themselves, because it's associated with a range of different symptoms. And these symptoms are often cyclical in nature, and they include a range of pain symptoms such as pelvic pain, pain with periods, pain with sex, pain passing urine, pain opening the bowels. Endometriosis can also be associated with difficulty passing urine, increased frequency of urine. It can also be associated with diarrhea and constipation. And it can lead to fatigue, and we don't really understand why that is. And the resulting symptoms themselves can also lead, not surprisingly, to low mood and depression. What causes endometriosis? Well, this is the big question, and something that we've been trying to better understand in Edinburgh. We think that pelvic endometriosis is likely due to what we call retrograde menstruation, or at least that contributes to some extent to the disease. So this is the fact that tissue at the time of menstruation goes back up the fallopian tubes into the pelvis. But we know this happens in around 80 to 90% of women. So why this tissue in some women sticks and forms lesions and not others is the big question, and something we're trying to better understand. The other thing that we don't fully understand is why these lesions cause pain. We know that the lesions form their own blood and nerve supply, which in part contributes to why people experience pain. But it's probably much more complicated than that, because we know that if you experience pain for a long time, this also leads to changes in the central and peripheral nervous system. How is it diagnosed? Well, many of you who've heard of endometriosis will sadly have heard of the figure that's within the UK that's attributed to the delay that we see in the diagnosis of endometriosis, a delay of anything between 7 to 8 years. And this is due to a combination of factors, a lack of awareness around the condition, the fact that the symptoms of endometriosis can cross over with other conditions, but also the fact that actually it is difficult to diagnose. We don't have a non-invasive biomarker, a simple blood test that can diagnose it. If we a patient presents with ovarian endometriosis, which is shown on this image here, you can imagine that this can show up on ultrasound scans. But if a patient presents with other types of endometriosis, it's much more difficult to diagnose, and we have to diagnose it by surgery. So patients have to undergo a general anaesthetic and keyhole surgery or a laparoscopy to make the diagnosis. So this again contributes to this delay, and you'll hear a bit more about this when Priscilla talks and later on in Lucy's presentation. And how is endometriosis treated? Well, broadly speaking, it can be treated with painkillers, over-the-counter painkillers, but within the hospital setting or within the general practice setting, it's either treated by surgery to remove the disease or by treatment with hormones which stop the ovaries producing estrogen, because we know that estrogen from the ovaries seems to drive the endometriosis development. And the way that we can do that is by delivering a number of different hormones, either by tablet, by injection, even by implant, as you can see here, and we'll hear a bit more about this in Lucy's presentation. But the big message that we're always trying to get across is that endometriosis cannot just be managed by a doctor, a single specialist. It involves a range of different specialties, from a general practice to specialist nursing, to pain medicine specialists, to colorectal surgeons, urologists, as well as gynecologists. And increasingly there's a role for psychologists and physiotherapists in the management of endometriosis. So it's really very much delivered by a team. And I'll now pass on to Priscilla, who's going to talk a bit more about the diagnosis journey. So thanks, Priscilla.
Hi everyone. For those of you who haven't met me in the past, I'm Priscilla. I'm one of the clinical research nurses, and thankfully through often times I speak to patients offering them clinical trials which they may be able to take part in, and usually these trials are run by Professor Andrew Horne and Dr. Lucy Whitaker here in NHS Lothian. And at the very end, as Professor Horne has mentioned, we'll talk a little bit about research and the research opportunities which we're running at the moment. So my bit is about the journey, and one of the things I wanted to mention is not everyone's journey is going to look exactly the same when it comes to endometriosis. There is not a path that we always go down. I hope that I can give you an overview of what it might look like for those of you who don't have a diagnosis, or are struggling to get a diagnosis, or striving for a diagnosis as well. And also, please do not be discouraged if I talk about all the possibilities. It doesn't mean that you're going to go through all of these and you're not going to see all of these clinicians. It's just to give you an overview of what it might be like. So ideally, obviously, a journey is from A to B. You want it to be short, you want it to be efficient, and you also want it to be very straightforward. And if you have symptoms of endometriosis, what you want it to look like is, from first symptoms, very quickly you obtain a diagnosis and a tailored approach management plan, which is really beneficial to you and how it works, and how it can help you with the management of those symptoms. Unfortunately, as Professor Horne has mentioned, the journey can sometimes take up to, on average, 8.5 years in Scotland, and we're trying to make that, change that and make that a lot shorter if possible. Unfortunately, COVID has not been very kind to any of the services, but we're trying to change that with a lot of research, etc. So usually a journey with for a patient who has endometriosis looks a little bit more like this. And again, I don't want you to be discouraged, because you might be like, oh my goodness, there are patients that go to their GP with initial symptoms, and then they may get referred very quickly and have a very quick diagnosis of their endometriosis. But oftentimes you will find that when you do have your first symptoms, you might go online and do a little bit of online research, speak to friends and family, perhaps you're thinking, okay, I'll go to my GP. Your GP may say, well, we'll try possibly giving you some hormones because you're in a stage in your life where you can take them, you're able to, etc. And you might feel you're in the right frame of mind for that. And then it could be that in actual fact you get referred to a gynecologist in the hospital, and then more tests are carried out. And after those tests, it could be that you try some medical treatments, or you try having acupuncture, things like that, or it might be that you have surgery to have a concrete diagnosis, because surgery is the only way to accurately diagnose endometriosis. And obviously we're trying to change that in other ways, and I'll come to that as well. So I'm not going to cover the symptoms that Professor Horne has mentioned already, but it can sometimes feel a little bit of, some patients report it as a backward journey sometimes, because you may have surgery for perhaps a different condition. You may need your appendix out, you may need, you may have a cyst and they don't know what sort of cyst it is, and then it may be that you put two and two together and you think, those periods, they were horrendous all along. Of course, it all makes sense. I'm knackered, I've got symptoms of IBS, etc. And it's all putting a puzzle together. And then, as Professor Horne has mentioned, the multidisciplinary approach, I thought I would just go into all the different professionals which you may encounter. And as I say, you don't not need to see the whole list of professionals here. It may be that first stop shop could be your GP is managing your symptoms well, and you don't need to have specialist sort of input depending on where you are in your life. It's all about what your goals may be, and it could be that for someone it's really important to not have periods, so your GP can help you with that and not have to investigate further. It could be that it's very debilitating and therefore you do want a diagnosis, you do want an answer, and that's completely understandable. So first up, you may see your GP, and like I've mentioned, they could actually provide you with some hormonal, some holistic sort of treatments, some physiotherapy, etc. Gynecologists usually what you would be referred to your local hospital, and I've also put their gynecologist at a BSG centre. Now, if for those of you who don't know what the BSG centres, just specialist centres of excellence across the UK who have got a large team specialising in endometriosis, and also who may see the more complex cases of endometriosis, and Edinburgh is one of those centres. You may see the endometriosis specialist nurse who can give you lots of tips and fantastic advice. Also try some new medications, which Dr. Lucy Whitaker is going to talk about. You may see a pain specialist, especially if pain is a real issue and it's difficult to stay on top of. If we're thinking actually it may be more complex because you're not, it may be that the patient comes to us and they're not able to take hormones, they're not able to try other medication because it could interact with the other medication they're taking, etc. So sometimes we seek advice from them. We also have a fantastic pain psychologist, and the last thing that I would want as a message here is, because I've had some horror stories of clinicians who have mentioned, oh, it's in your head, it's all in your head. And that can be extremely damaging and can actually take away the confidence that you have in the team that's looking after you. A pain psychologist is there to help you understand what pain is, how we can cope and with pain, and actually provide you with coping mechanisms with the pain that you have. And your pain is very real regardless. So when you hear the term psychologist, please don't think, is it because they think it's psychological? That's not the idea at all. We also, I've got physiotherapist, I've got two forwards, never mind. Physiotherapists are fantastic, and she can help, or he can help with, for example, back pain, hip pain, if you've got a lot of pain in your pelvis, if you're finding particularly painful. They can sometimes give you some dilators that you can try. So it's all about putting together what the best team is for your symptoms and trying to get on top of it. Acupuncture, it works wonders for some patients, and if that I've seen some fantastic feedback from patients who have said, actually, I can see an acupuncturist and have really good relief. So we encourage that in the clinic as much as possible as well. In your journey, you may meet in clinical nurses and support workers, for example, in the clinic, in the preoperative assessment, and also theatre staff. So they're just there to obviously make sure that you're safe, that you're going to be comfortable, and to make sure you're well looked after. I've gone a bit fast. I'm so sorry. I had the research team there. That's me. That's where I come in. And I would love to talk to you about research all day, every day, and sell it on QVC if possible. And I'm going to talk about it a little bit later. So with regards to endometriosis, as Professor Horne has mentioned, it's very difficult to diagnose, and it's about piecing things together. Now, you may have tests which may be indicative, but not a definite diagnosis of endometriosis. And I'm just going to run through some of the tests that you may encounter and you may be suggested from your doctor to have. So, for example, you can have an ultrasound, quite rightly, like Professor Horne has mentioned. Sometimes we do ask for a transvaginal ultrasound, and I promise you when I say this, there is nothing we have not seen. You know, it may be have feelings of embarrassment, for example, if you have a vaginal examination as well, because we sometimes check to make sure that the organs are mobile and they're moving freely, and there's no kind of like adhesions and no deep endometriosis that we can feel, that we know for sure, that we think, oh, actually this should not be here. And what I mean by saying we've seen it all, we will make you feel relaxed. We will not do anything that obviously is not comfortable for you, but sometimes these things are necessary. Blood test as well, we sometimes look for a bit of inflammation, making sure that there's not an underlying cause for the pain, that it's not endometriosis. We are hoping to look for a biomarker which can possibly detect endometriosis in a blood test rather than surgery, which is, you know, invasive. And we know that not everyone is going to want to have surgery. You may be absolutely petrified, and that's understandable. For reasons, you may think, actually, my symptoms are quite well controlled. But the gold standard is for endometriosis diagnosis is to have a diagnostic laparoscopy, because it's the only way to visualize the endometriosis in the pelvis or wherever it may be in the organs. You may undergo bowel investigations and investigations to do with your kidneys, your urology, and we also recommend that you have STI screening. So just to rule out any causes of your pain or symptoms that could be treated quite easily, for example, with antibiotics. And unfortunately, with endometriosis, sometimes you can be diagnosed with more than one thing. So you could have endometriosis, you could have irritable bowel syndrome as well. And those things in conjunction can be a little bit difficult to manage. So sometimes we, most of the time, we'll try and give you advice on how to manage them as well. Now, to go to the next slide, I've put here life after surgery, but in actual fact, what I wanted to say was you may prefer not to have surgery, and that's absolutely, you know, up to you, because it is an invasive procedure. It is keyhole surgery, but by no means it's minor surgery. People believe that, you know, they think because it's keyhole, it means, oh, it's just a minor operation. So we counsel you with the risks outweighing, you know, the benefits to you. It could be that you decide, actually, my symptoms are not too bad. I'm just going to try some medical sort of options that Dr. Whitaker is going to talk about. I wanted to give some advice regarding the success rates of surgery as well, with regards to pain improvement. And obviously the idea is that we want to improve your pain or symptoms as much as possible. And 62.5% at 6 months of patients actually reported an improvement, so which is a good number. But then at 12 months, that goes down to 55%. So what I wanted to say was, obviously 37.5% of patients at 6 months will have felt little to no benefit. And then there's also the 45% at 12 months that may not have felt the benefit. Now, Dr. Whitaker is going to tell us a little bit more about it. There's 2 types of surgery, and she will go into this. And basically, one is diagnostic, so you can have a diagnosis. Sometimes you have to go on to have a second surgery where more time is allocated, and this second specialised doctor comes in and helps out with the more difficult areas that may need to be treated. Or it could be that at the same time of the diagnostic laparoscopy, you can have treatment depending on what the severity is. So I hope I've not discouraged anyone from all of this. It sounds like your journey should be from A to B, and it's anything but it's all about very individual symptoms that you have and piecing it together. But I'm now going to pass on to Dr. Whitaker, who's going to tell us a little bit more about what to do and what options may be when you experience painful symptoms.
Thank you very much, Priscilla. So hello everyone, my name is Lucy Whitaker. I'm a clinical lecturer at the University of Edinburgh. So I work in the EXPPECT service, providing some of the clinical care for our patients with endometriosis. And I also have an academic role within the university, working alongside Professor Horne, typically in clinical trials, to try and improve pain management for endometriosis. And what I'm going to talk to you today is having gone through, is this going to let me? Yes, there. Having gone through the diagnostic process and have been given that diagnosis of endometriosis, what are the options for pain management? And broadly, these are considered in 3 separate areas. So we've got surgery, we've got medical treatments, and this includes hormones, painkillers, as well as some other medications that we can give. And then there's also the approaches of encompassing factors such as self-care, physiotherapy, psychology, dietary modification, complementary therapies, etc. So I'm going to go through these all individually. So we'll start with surgery, if it will let me. Perfect. So firstly, when we're talking about surgery to improve pain, so we've moved away from the use of surgery as a diagnostic, so to give people that investigate their pain, it's to actually treat their pain. And when we're thinking of the role of surgery for this, we always need to be balancing up what are the pros and the cons, the risks and the benefits. So particularly for the pros, what is the symptom we're treating and how likely is that treatment going to be to improve that particular symptom? And that's got to be balanced against the risks of surgery. Now, there are general risks for our surgery. Also, depending on the type of surgery that's planned, those risks will alter. So clearly removing endometriosis from somebody's bowel is a more risky, significant procedure than removing small lesions of peritoneal endometriosis that are away from any important structures. But there's also the individual factors which contribute to risk of a procedure. So that's factors like someone's weight, particularly if people are very significantly overweight. That can introduce additional complexity to the operation itself, but also can make the anaesthetic more complicated. And there are other medical conditions that can also factor in what the risks are of anaesthetic. And finally, also what previous surgeries an individual's had. So if they've had lots of previous surgery in the past, and therefore there's a possibility of having developed scar tissue within the abdomen, that increases the risk. So it's this constant balance of weighing up of options. And against that, we also need to think about what are the alternatives to that option for that individual, and also how that fits in with their fertility requirements. So whether or not they're actively trying to conceive, whether or not that's something they wish to pursue in the future, but not at that particular point. Or indeed, is this something that doesn't have an impact at all on their decision-making process? So also when we're thinking about surgery for endometriosis, there's the type of surgery we're going to do. So when we need to decide whether or not we're operating just on the endometriosis itself, or are we removing other organs? So in certain circumstances, that might be the ovary or a section of bowel or removing the womb, so doing a hysterectomy. And in terms of the treatment to the endometriosis itself, there's broadly speaking 2 different approaches. So we can destroy the lesions using heat or laser, and that's called ablation, or we can cut the lesions out. And for the different types of endometriosis, the sort of pros and cons of ablation versus excision are slightly altered, because I think this is one of the really key factors, is that we need to stop thinking about endometriosis as one single disorder, but these 3 very distinct subtypes, because they've all got slightly different management strategies. And so it's about not putting them all together and sort of comparing apples and pears, as it were, but thinking about these 3 different subtypes and the pros and cons of the different intervention for the different subtype. But that also has to be taken alongside what the symptoms that individual is experiencing. So I'm going to just go through these. Oh, come on, Zoom, do your thing. So first of all, I'm going to talk to you about deep endometriosis. So there is evidence to support the role of medical treatment in improving pain associated with deep endometriosis. But by and large, surgical treatment to completely excise, so cut out the disease, is generally considered to be the treatment of choice. Again, this does have to be a balance of risk and benefit, because surgery for deep endometriosis, particularly bowel involvement, is a more complicated operation and can be associated with serious or potentially even life-threatening complications, although thankfully this is a rare occurrence. But it is a more complicated operation than some of the other types of surgical interventions for the other subtypes of endometriosis. But on the positive side, that surgery is likely to improve pain for deep disease. Now, the evidence we have for that is predominantly looking backwards, so taking large groups of women who have undergone surgery for deep endometriosis and looking what's happened to their pain. And in the UK, we're really fortunate in the setup that we have, that complex endometriosis is typically managed in these BSG centres. And we all have to report our data and our operations that we do, what our complication rates are, but also the patients get followed up for 2 years after surgery. And this has given some really compelling evidence demonstrating that surgery can be really effective for really all types of pain and improving quality of life at 2 years. But what I would say is that firstly, this is a looking back type studies, and there's a real lack of studies where we take a patient who presents with deep endometriosis and pain symptoms and randomizes them into different treatment options. So some get surgery, some get medical treatments. And there's a real need for those type of trials, so that when a patient comes to us with these symptoms, with these pains, we can say, firstly, surgery is likely to improve your symptoms, but it has to be balanced against the risk of surgery. But also we can say, medical treatments, what are the pros and cons of those? And also for that individual, what we want to be able to answer, which treatment is most likely to help your symptoms, to allow that individual to make an informed decision about what treatment strategy they want to go to. And there's a big study running across the UK trying to answer some of these uncertainties. So that's starting later on this year, and that's called Diamonds. That's specifically people for deep endometriosis who've got pain, and half of them will get medical treatment, half of them will get surgical treatment. And so we can actually properly discuss with patients what treatment might be the best to alleviate their symptoms. So, sorry, there's just a little bit of a delay. So in terms of endometriomas, again, so this is endometriosis cysts on the ovaries. Now, again, there is a role for medical treatment in managing these, but again, rather like deep disease, overall, we tend to favour surgical treatment over medical treatment. And when we do surgical treatment for endometrioma, particularly for large end, what we like to do is, rather than ablating the disease, so burning it away or using lasers, we prefer to excise it, so cut out the capsule of the cyst. And the reason for this is that this significantly reduces the risk of recurrence of endometrioma compared to if we just drain or ablate the cyst capsule. But again, it's this risk-benefit balance, and we know if we operate on the ovary, we will do something to reduce the amount of eggs left in the ovary, so what we call the egg reserve. And so for someone who fertility is a priority, this can be a really important factor in the decision-making of whether or not we go ahead with surgery, knowing that we might slightly reduce the number of eggs left for a future pregnancy, but also there is a very small risk of, particularly if you're operating on both ovaries, that we reduce the egg count so much that we can bring forward the time of menopause. So this risk-benefit balance. So we think there's some better quality evidence perhaps for the role of surgery for endometrioma, but we still, particularly in sort of the smaller endometrioma, we're still really rather uncertain exactly how to counsel patients of which is the best way to go ahead to address their pain symptoms. So thirdly, and the one that I actually think is the most complicated in terms of decision-making, is superficial peritoneal endometriosis. So the small peritoneal lesions, I say superficial, not because their symptoms are superficial, but because they lie on that surface area of the lining of the abdominal cavity, the peritoneum. And as I said, this is the most common type of endometriosis, affecting around about 80% of individuals. And also, this is one of the ones that is most challenging to diagnose, because it doesn't show up in a scan, there isn't a blood test for it. So typically this will get diagnosed by laparoscopy. And at the time of laparoscopy, the NICE guidelines, the guidelines that we use across the UK, suggest that we should consider treating these lesions at the time of surgery. And they say there's no particular benefit of excision over ablation. The evidence base just isn't there to tease out which is better. But they do say, overall, consider treatment. And the reason they recommend this is based on 3 trials, all of which at 6 months demonstrated that there was a benefit of doing surgery to treat the lesions compared to just looking at them alone. However, some of the challenges are that those 3 studies are quite small studies, and only one of those studies followed up the patients beyond 6 months, so saw what their pain symptoms were at a year, but they didn't follow them up any further. And we know that particularly with superficial endometriosis, there's a really high rate of recurrence or persistence of symptoms. And certainly around about at least 50% of patients will represent with persistent symptoms, and the majority of those within 2 years. So I think we are not fully certain about what actually the benefit, particularly the long-term benefit is of surgical treatment to superficial endometriosis. And I think also we're not fully certain about what the risks of surgery are. So as Professor Horne said, with endometriosis, you can start to have nerve damage, and then that can contribute to the pain. But what we don't know is whether or not surgery in itself can contribute to that nerve component to the pain, which is what we call neuropathic pain. So it's a real difficult balancing act of trying to work out what the best thing is to do for superficial endometriosis. And I think increasingly we're becoming more aware that perhaps it isn't necessarily the effective treatment that we once thought. And that's certainly been recognised in our scientific community and clinical community, but also I think there's increasing awareness amongst patients that perhaps surgery might not necessarily be the be-all and end-all for superficial disease. And so to try and work out who surgery will benefit, we're running a large study across the UK called the EXPPECT study, which is specifically for those with superficial peritoneal endometriosis, to try and work out if we can better predict who is and who isn't going to benefit from going through surgery. And so, just to recap surgery, it's all about balancing the symptoms, how likely the surgical treatment is to improve those specific symptoms, balancing against the risks of surgery. And I think one of the key things when we're thinking about pros and cons, and also reflecting on some of the uncertainties about these treatments, is that we also need to consider what the alternatives are for these individuals. Because if there aren't any alternatives, then the risks of surgery become perhaps less relevant if there are no alternatives and that patient's quality of life is significantly impacted upon. So what are alternatives? So we'll start with medical treatments. Now, there are broadly 3 components to the medical treatments that we prescribe. So firstly, painkillers. Typically paracetamol and non-steroidals, so that includes things like ibuprofen, mefenamic acid, naproxen, diclofenac. What we are trying to move away from, though, is the use of opiates, and there's several good reasons for this. So firstly, opiates come with lots of side effects, and I think the really key one within endometriosis is impact on the bowel, and the fact that they are extremely constipating, and so this can exacerbate any coexisting IBS, as well as in itself precipitate pain flares from endometriosis. We're all very conscious of the addictive potential of opiates, and I think all of us are aware of what's happened across the Atlantic in America with the sort of issues they've had over there and the long-term consequences of opiate use. But I think the other thing is that we recognise that long-term chronic use of opiate medication becomes more and more ineffective at times. So you've got significant side effects, but also it's actually not working very well as a painkiller. The other medical treatments include neuromodulators, and I'm going to come back to neuromodulators. And then the sort of third strand of our medical treatments we use at the moment is the hormonal suppression. So there are several different types. So you can have the combined pill, the mini pill, the progesterone injections, so the Depo-Provera, progesterone coil, as well as the progesterone implant. And we also have the use of putting people into a temporary reversible medical menopause. Now, there isn't one of these treatments that's better than the other. They're all overall as good as each other, but they've all got slightly different side effect profiles. And so different treatments will suit, hormonal treatments will suit different patients. And it's about balancing about things like sort of what is the medium-term fertility intent, what are the side effect profiles, and also what an individual's tried before. And sometimes there might have been something that was effective for pain management but had side effects. So sometimes switching to different class members can be a really effective way of managing their symptoms. And equally, sometimes having tried some of the alternatives, we go back to a previous treatment because actually, on balance, that was the one that worked best with the overall least side effects. But I think this decision making about the right hormonal treatment can be quite confusing, and there's some really helpful guidance from NICE, people who developed our guidelines for patients to try and work out which might be the right hormonal treatment for them. I mean, clearly what we do need to recognise is that these hormonal treatments are all contraceptives. So for someone actively seeking to conceive, this is not going to be an appropriate treatment option. And I think that reflects one of the challenges that we have within our medical treatments we have for endometriosis. But I'm going to come back now to neuromodulators. So neuromodulators are medications to treat neuropathic or nerve pain. And what I mean by neuropathic pain is pain that comes from damage to nerves or the nervous system not quite working as it should do. Now, why is this relevant in endometriosis? So first, I'm going to talk to you a little bit about how normal pain processing works. And this is an evolutionary protective manner. So say you are walking along and you stand on a nail, you have a pain, and that gives you a pain stimulus. Now that is detected by a pain nerve, which sends a message along the nerve fiber, then it goes up another fiber all the way up your spinal cord, and then that message is then sent into the brain, and it recognizes that a painful thing has happened, and it sends a message back going saying, take your foot off the nail, and that should help, and that helps prevent further damage. So this is an evolutionary process designed to protect us. Oh, right, sorry. So in endometriosis, this process gets affected and starts working in an abnormal fashion. So not only have we got a pain stimulus, but we've got a constant pain stimulus, which can go on for a long time. It can ebb and flow in some measures, often sort of reflecting where you are in your reproductive cycles and menstrual cycles. But you've got this chronic pain stimulus, and as well as that, you've also got a lot of inflammation. And the combination of this, plus lots of factors which are secreted by the endometriosis lesions themselves, all act on the nerve fibers and start making it very overexcited, these nerve fibers very overexcitable. So they start to perceive a pain signal much more easily. Now, this is further worsened in that endometriosis causes the growth of new nerve fibers. So now we have even more nerve fibers sending a pain signal following fairly minimal stimulation, and sometimes even after we've fully removed all the endometriosis. And so because we've got this abnormal functioning of the nerve fibers, this neuropathic component to the pain, there's a role for medications that can directly act on the nerve fibers to treat this type of pain. And these are the neuromodulators. So these are broadly split into three different categories. So we've got a group of compounds called tricyclic antidepressants. Now, These are actually by and large not used as antidepressants anymore. They're used predominantly for neuropathic pain. It's partly because they actually work very good antidepressants. We also have the gabapentinoids, so things like gabapentin and pregabalin, and also things like selective serotonin reuptake inhibitors or noradrenaline reuptake inhibitors. So these are drugs like duloxetine and fluoxetine. And rather like hormonal treatments, there isn't one neuromodulator that's better than the others. They all work in slightly different ways and have got different side effects profiles. So sometimes it's about trying to work out both in terms of the pain and individual experience, but also the other factors, so things like their impact on sleep, fatigue, bladder symptoms, bowel symptoms, about which one of these might be the best one to try first. And then it's about balancing, is it effective, what are the side effects, and trying to get onto an appropriate level so that we can start to try and reverse some of that neuropathic component to the pain. So, as I said, some of these were developed as antidepressants, and I want to reiterate what Priscilla said about this, some of these misconceptions about antidepressants, mental health, endometriosis. And I suppose what I want to say, that one of the key factors is that the relationship between mental health and pain is really complicated, irrespective of what condition is causing it, be it arthritis, diabetes, or endometriosis. It is really complicated. So if we go back to our little pain processing, so in endometriosis, not only have we got all these things happened at the sort of what we call the peripheral nerve fibers, so the nerve fibers going into the lining of the abdominal cavity, but also we've got changes within the brain. And the pain is initially processed from the spinal cord as it goes into the brain in an area of the brain called the thalamus. Now, not only is this area really important in pain processing, but it's also really important in mood processing. And so anyone who's got anxiety or low mood or depression will typically have abnormalities in the thalamus, so this area of the brain. And particularly they often get low levels of serotonin, which is one of the key hormones involved. Being sabotaged by PowerPoint. So where was I? So serotonin. So we're in the thalamus. It's been altered by, it can be altered by mood, but it can also be altered in pain. And overall, we've got in both conditions, we can have a reduction in serotonin. So if you've got low levels of serotonin, because we've got that will impact upon your mood, but will also impact upon your pain processing. So it's no surprise in patients who've got low mood anxiety will also have abnormalities of their pain signal. And I think the key thing, it's not that the mood disorder is causing the pain, it's the same process affecting the serotonin levels that's impacting both on mood and on pain. And I think it's really important to address this misconception that antidepressants are sometimes prescribed, and it's not because the clinician thinks the pain's all in your head. It's because we need to address these serotonin levels and starting to overcome this vicious circle of abnormal pain processing and the interplay with mood. And as part of this, I think we really recognise that it's important to address all factors that contribute to pain. So not only mood, the role of medication, surgery and addressing the lesions, but also all the other factors that impact upon that pain experience, be it social factors, behavioural, psychological factors. And these are all opportunities for us to interventions to overall try and improve pain and quality of life. And different individuals will need different components of these. For some, medication, surgery will actually be very effective, will all be needed. But for other individuals, either those are not appropriate or ineffective. And I think that's the region when this multidisciplinary approach becomes even more key. So it's not just the role of the gynecologist or the general practitioner, but also the role of factors such as pain psychologists, pain physicians, physiotherapists, nurse specialists, this multidisciplinary approach to all these facets of pain to overall improve quality of life and pain management. I think we also recognise that we don't have all the answers, and there absolutely is a role for complementary therapies. So things such as traditional Chinese medicine and acupuncture, some patients have found really helpful. I think other things that we are also really excited about is the role of dietary supplements, such as things like omega-3 or turmeric, and cannabinoids is also highly topical at the moment, and particularly for these two, there are some really exciting preclinical work that's been done, sort of demonstrating reasons why these might be effective treatments for endometriosis-associated pain. What we are lacking, though, is big clinical trials to really determine exactly how effective all these treatments are and what the safety profiles are. So I think there is a role for these that these all can play, but I think we all need to be open about the evidence base or lack thereof for some of these treatments, but different things will suit different individuals. And I think not only do we recognise we don't have all the answers, but I think particularly over the course of the COVID pandemic, when access to medical treatments, surgical treatments was so severely restricted that it really threw into sharp relief the importance of having self-care strategies. And I also think it's extremely important to give the option of control over your treatments. I think particularly for many individuals with endometriosis, it's had such a pervasive impact on all elements of day-to-day life, and that loss of control, that long diagnostic journey. So having something that you can do to exert control, to manage your own symptoms, I think is really important. And so in terms of other self-care strategies, aside from those complementary treatments that I've already mentioned, there are other factors such as diet. Now, there isn't one endometriosis diet that's effective for everyone, but many patients have reported effective response to things like either cutting out gluten or lactose, or following a low FODMAP diet, or cutting out sugar. As I said, there isn't one specific diet that works for everyone, but for different individuals, they will have different triggers that contribute to their pain. So sometimes keeping a food diary, trying to work out your own personal triggers can be really helpful. What I would say is that I think really restrictive or elimination diets, I don't think those are a good thing, not least because that's going to limit you from a whole lot of incredibly important nutrients. Other factors in terms of self-care, so exercise, and now for some people that will be aerobic exercise and getting all the endorphins from that. Other people, that might be a trigger for their pain. So for others, things like yoga can be. Oh dear, we'll get there. Yoga, this plays in a really pretty sequential way, but I think PowerPoint is against me. So aerobic exercise, things like yoga. I think also topical treatments, so things like heat, be that a hot water bottle or a thermal pack, or factors such as TENS machine can be really effective. And I think also because particularly heat packs or TENS, they're quite discreet, they can be really useful when someone's at work and not wanting everyone else to know exactly what's going on, but try and give them some way to help manage their symptoms and allow them to function in the workplace. I think also factors that are involved with emotional well-being, stress management, sleep quality is really important. But I think this idea of pacing is incredibly important. We see a lot in our patients, particularly the ones who've got very difficult pain to manage, this sort of desire when you have days that are better to try and fit as much as possible in, and actually sometimes doing so much almost then precipitates a pain flare. So trying to have a more even approach today, and then that also brings into a slight more predictability in terms of pain symptoms. So it means you can plan, and having that ability to look forward, to plan, be able to know that you can do something, I think is hugely important. And alongside this, factors such as mindfulness, grounding, acceptance, treatment, I think can be really helpful in terms of self-care, mental well-being, but also those positive impacts back onto pain processing and those serotonin levels, which are so key within pain management as well. Don't know what's going to happen with PowerPoint. So we've articulated some of those on our EXPPECT website, which has got lots of areas for information for patients, both about what endometriosis are, what some of the traditional treatments are for it, but also for those strategies for self-care. And if I've talked a bit today about evidence and pros and what the evidence base is out there for, and I think this journal article, I realise it's in the scientific press, but anyone can access it. This is a really well-written paper, just outlining all those different self-management strategies and what the evidence base for that. And I think that can be really helpful for some people. I appreciate some of it is in slightly more technical language, but actually I think this has been a really well-written paper and very accessible language, so some of you may find that useful. So in terms of what I've talked about today, I think I've given you a brief overview of the sort of various strands of treatment that we have for offer. I think key is that for many, surgery or hormonal treatments can be really effective. So I don't want anyone to go away with sort of a negative, go, oh, none of these things will work, or they're all going to cause terrible complications or side effects. For many women, we can bring about good pain management with relatively less significant interventions. But I think also it needs to encompass what the right treatment is for that individual, encompassing what her individual preferences are, what she's tried before, what that individual's risks are, but also encompassing what their fertility and views are on maintaining the option of fertility, or in terms of role of hysterectomy and at the sort of further way down there. I think it is really important to have a multidisciplinary approach, particularly in these more complicated cases. And actually, in an ideal world, everyone with endometriosis associated pain, I think should, in the future, I would hope, is going to have more access to factors such as physiotherapy, psychology support, and formal pain management. But I think also it is key that we need to be honest with individuals who come to us about what the limitations are, about our knowledge of how effective a treatment is like to be from, and our limitations with knowing, being able to predict what's going to work for which individual. And so with that very elegant segue, I'm going to hand you over to Priscilla just to talk a little bit about some of the research we're doing to try and address some of these uncertainties, so that when we see patients with endometriosis and with pain symptoms, so that we can better advise them about what is most likely to be the treatment that's going to help their symptoms. Thank you very much.
Thanks, Lucy. I am predominantly a research nurse, and my role and our role as clinicians working in the EXPPECT clinic is to offer trials to patients who may be eligible to take part in those trials themselves. And taking part in research can mean a lot of things. It can mean filling out a 10-minute survey online, or it could mean trying possibly a new treatment for endometriosis. But I've put some of the current projects and ones that have been in the past, and some that we're thinking about in the future here. And I'm being drawn, GAP2 is a past project that was looking to see if gabapentin was helpful for women who had undergone a laparoscopy, but there was no endometriosis visualized, and we found that in actual fact gabapentin was not much better than placebo in helping with symptoms and had quite a few side effects. So as you can see, this research can actually shape the informed choice that you may make, and you might think, actually I'm not going to try that because I'm in that same boat, or I will give it a try because some patients did find it beneficial. We also have had a trial on looking at omega-3 fish oils and see if that could help with endometriosis related pain. There was also, you may have taken part in understanding and managing endometriosis, and that was us coming to you when you were going to have a laparoscopy, for example. We would ask, could you fill out some questionnaires so we could see what your symptoms are, and also can we at the time of surgery collect some of a sample so that we can use that in a lab to have to shape the future of other trials, because obviously it's driven by need of the patients. So we also had a very successful trial that was looking at EPIC, and the data at the moment is being analysed, but it was very widely shown on BBC. We had a lady who found it very beneficial at the time, called EPIC, and that is looking at how a supplement called dichloroacetate could help with endometriosis related pain. We found that dichloroacetate is a supplement that actually reduces lactic acid, and athletes take it. It's sometimes used like Dr. Whitaker was mentioning, other drugs that are repurposed in cancer trials, etc. And basically we found from taking samples from ladies like yourself who may be listening, that in peritoneal fluid, and fluid that just sits in your tummy, that doesn't really have much of a papas, women with endometriosis had higher levels of lactic acid. So we thought, well, someone very clever in the lab, not me, thought if possibly we can have this DCA reduce the lactic acid levels, could that help with endometriosis related pain? So currently we are running EXPPECT, as Dr. Whitaker also mentioned, and this is the trial where we're looking to see if we can have more robust evidence regarding the treatment of superficial peritoneal endometriosis. And we're asking ladies to who don't have a diagnosis of endometriosis and are currently on the waiting list for laparoscopy, is would they be willing to complete some paperwork, some questionnaires before surgery, and then be randomized. So that basically means at random be allocated by a computer whether they were undergoing a diagnostic laparoscopy alone. So that's basically what they would be, the surgeon would be looking to see if there was an endometriosis, but not have treatment of excision or ablation or burning or the cutting like Dr. Whitaker was mentioning, or in actual fact have the opposite, which is diagnostic laparoscopy, but you do have it treated. But the caveat to this was that you would be told after your surgery, yes, you do have endometriosis, but you would not be told whether it's been treated or not. So you would be blind to the fact whether it's been treated, and then that way, by completing some questionnaires at 3, 6, and 12 months, you would be completely unbiased as to how you completed those questionnaires, and then hopefully that should give us a bit of more of a robust evidence-based as to what we should be doing in these cases of superficial peritoneal endometriosis. We're also looking to take some blood samples to see if we can see a biomarker, like I was saying earlier on, for this, see if we can see any evidence of endometriosis from the blood itself. We're currently running EndoTech, which is a great trial to take part as well, where we're asking patients to wear a smartwatch, and it's basically, it's not like your Apple Watches and your Fitbits and Garmins. Basically, it measures quite a bit more. It looks at light, it looks at activity, it looks at the same time, we ask you to complete some questionnaires on your daily pain, etc., fatigue, and we ask you to wear it for 6 weeks. Edumed is the similar to the understanding and managing endometriosis, and it's the collection of samples for a lab, and it's driven by the need of the patients and also of the scientists looking into endometriosis. Regal is one that we're looking at the moment, and I've written some notes here, and it's basically comparing long-term GnRH analog. So that's a very big word, but it's basically an injection that you can have that stops your ovaries from releasing any hormones, and you have that every 3 months, versus having a repeat laparoscopy if you're still experiencing pain, if you've got a diagnosis of endometriosis. In the future, we are hoping to run EXPPECT, which is, for example, EPIC, which is the one I was talking about before, we gave all our patients the dichloroacetate, but EPIC2 would be doing the placebo controlled, so basically given 50% of the patients a dummy pill or a sugar pill, and 50% the actual dichloroacetate supplement to see if that helped. Diamond, I've got some notes as well. It's comparing early planned laparoscopy surgery with or without medical treatment versus medical treatment alone in women with deep endometriosis. Advantage is going to be a consortium looking at all types of visceral pain. Now I thought, oh God, how do I explain visceral pain? But it's pain felt in your organs or that seems to come from your organs, and we're looking at a lot of other conditions, for example, like pancreatitis and things like that. And then we're also going to be running EndoGut, which is looking at the microbiome, which is the good and bad bacteria in your gut, and how diet can affect your endometriosis pain, or how it can actually either improve it or actually worsen it. So there's a lot there in that slide, and this is not exhaustive. We do have other little projects that we're running at the moment, and research may not be for you. It may not be quite right at the moment where you are in your endometriosis journey, or it could be that actually you do fit the criteria. We approach you, and we hope that you don't mind us approaching you saying, would you like to take part? We usually are very grateful for any time just to explain what the trial may involve, and if not, please keep your eyes peeled for the results of these trials. And if anyone wants to learn more about them, I'll be more than happy in the chat. I'll put my email address, and you're more than welcome to email me to find out more information. And I think I'll pass back to Claire to see about the Q&A.
Sorry.
Oh, sorry.
Priscilla, if you just want to skip one more slide. We've just put up for, obviously we've talked a lot about what we're doing today, but just in terms of options for more information, I don't know if you've still got control, Priscilla.
Possibly, quite possibly. I don't think I do. I believe I'm viewing Professor Horne's screen. I don't know.
I've just been asked to give it control to you, Lucy, so I think you can move it on. Yep.
Okay.
Very confusing.
Technology. As you can tell, no one on this call is Bill Gates or anything like that. So just bear with us. Sorry, I speak for myself.
So yeah, it was just a little bit of signposting, so there's not other areas where you can get information about some of the components we've talked about this evening. I think we're all happy to take some questions.
Fantastic, thank you all. That was really, really interesting, and I've certainly learned a lot there. So it was wonderful to hear from you all. And we've had some questions sent in beforehand, and there's a few in the Q&A as well. So I'll start with the ones that were sent in beforehand. And the first one, I think it has been covered in the presentation, but is there any new treatment for endometriosis that does not involve hormonal treatments?
Thanks, Claire. So yes, you're right. I think we maybe did cover it. So there aren't any currently used in clinical practice, but there are non-hormonal treatments that are being studied, in particular the one that Lucy and Priscilla highlighted, which is dichlorastate, which we've studied in EXPPECT 1, and then Lucy mentioned we're trying to secure funding to do EXPPECT 2. So that's probably the closest we're getting to a non-hormonal treatment at the moment.
Great, thank you.
I suppose just to follow on from what Andrew said, I mean, there is some really interesting preclinical work that's been done on particularly on omega-3, which seems to change the endometriosis lesions themselves. So we are very excited about dichlorastate, but there are some other options, I think, particularly look at things like omega-3. And I suppose one can also consider the neuromodulators. They're not treating the endometriosis lesions themselves, but they are do have a role within pain management, and they are non-hormonal. So particularly some of the tricyclic members, we're comfortable prescribing those to people who are trying to conceive. So it is a medical treatment that they can have for their pain management.
Great, thank you, Lucy. The next question that came in is from someone who's pre-diagnosis. So they're 17 years old and told that she doesn't have PCOS but can continue on the pill until age 50. What is the next process for investigation for endometriosis when there are clear symptoms, a family history of endometriosis, and it's impacting on mental health? Would it be back to the GP to refer to an endometriosis specialist, I'm assuming?
I think that would probably be the most sensible approach, and then the GP may, I mean, obviously I don't know the personal circumstances, but may need to do some more imaging, or may even recommend a diagnostic laparoscopy. But I think definitely back to the GP. Yeah.
And Endometriosis UK does have a guide for consultations with GPs as well that could be useful for this query as well, which is available on our website. I will move to the Q&A questions that have come through. So first question on our Q&A little function is, as endometriosis is an estrogen dependent disease, are we likely to have levels that are too high, which exacerbates the disease?
So it's difficult to explain this. So it's more to do with local estrogen within the pelvis rather than estrogen in the blood. But so levels in the blood aren't necessarily indicative of an issue. And in fact, if you think about during your normal menstrual cycle, levels of estrogen go up and down anyway. So it's something we think more to do with, if you like, a sort of almost imbalance of hormones within the pelvis. But certainly we know that if you stop estrogen production altogether from the ovaries, it seems to help with pain, and most likely stops the disease developing and progressing.
Great, thank you. The next one is around referrals again. So are there criteria to be referred for pain management services?
Lucy, do you want to answer that one?
So I'm conscious we're doing this to a Scotland-wide audience. So there are, in all health boards, there is chronic pain management, and different health boards will have different criteria for who can refer to those. And for general chronic pain management, typically those can be referred to from primary care, so your GP can refer onto that. Within Lothian, we have the combined pelvic pain service. So this is a multidisciplinary team with a psychologist, pain specialist, anaesthetist, a gynecologist, and a physiotherapist, if I've forgotten anyone, within that. And this is specifically looking at individuals with chronic pelvic pain, and some of those will have endometriosis, other of those won't have endometriosis. So in terms of our referral process for that, that does need to come through gynecology. So we don't see people directly from primary care unless they've previously been under our service. So it goes through gynecology, partly to make sure that all the potential contributors to the pain have been appropriately worked up, and straightforward management strategies instigated before they then get referred onto. And part of that is about resources, and we are conscious that our service could be of benefit to many more than that we can accommodate within our service. I think so. That's why we have this process of ensuring everyone comes through gynecology first. I don't know, Andrew, if you want to add anything more to that.
No, I think that's a good summary of the system in Scotland. Thanks.
Great, okay. So the next one is someone who's been given the Mirena coil, which is working so far for pain. But their question is, what happens with the disease when taking hormones? Does it progress, but pain is masked by the hormones, or do the hormones help stunt or stop the growth? They're particularly interested in fertility chances in the future, and at the moment they're not ready for children. They're 24, but they would want to have them in the future. Yeah,
so this is a common question that we get asked. So the first thing is, we don't really know whether endometriosis progresses, because obviously to try and work that out, you'd have to repeatedly do, for example, a laparoscopy, a surgery, and try and follow someone, which obviously would be very, very challenging. We think that in some cases endometriosis gets better by itself. We think that in other cases it stays the same, and then in other cases it definitely does progress. So the problem then is when you add hormones into the equation. Whilst we know that some people feel better with hormones, we again don't really know exactly what it's doing to the disease itself. So it's a question we probably can't fully answer at the moment, and I think you shouldn't think of it as masking the disease, because it is still a treatment, but we know it doesn't actually cure the disease. So that's the first thing I would say. If it's helping you and helping your symptoms, that's a good thing. I think with regard to fertility chances, there's so many factors that affect fertility, and we always say to patients, just remember that 2/3 of patients with endometriosis will have no problems getting pregnant at all. And even in those patients, that third who do have problems getting pregnant, they often, if they need surgery, respond well to surgery, or if they do eventually need to go on and have treatment with IVF, then they often respond very well to those treatments. So I think always try and be quite positive about that side of things.
Great, thank you. The next question is, I have suspected endometriosis and have been given hormonal treatment, which is working, but I haven't been referred to a gynecologist. Should I be, even though treatment is currently working?
So I can respond. I know there's lots of questions in the chat. I can respond very
Yeah.
quickly to that. So we've got really good national, Lucy referred to the NICE guidance for this. So if you're given a treatment in primary care, as long as you've had a discussion around the fact that it might be endometriosis and it's working for you, you don't necessarily need to get referred. You can ask to be referred at any stage into secondary care, but if it's working for you and it's managing your symptoms, you wouldn't automatically be referred. The situation where you should be referred is if you're given a hormone treatment for up to 3 months, or even sometimes it can be a little bit longer, but usually around 3 to 6 months, and it isn't working for you. In those instances, the guidance is that we'd recommend referral into hospital care.
Great, thank you. It's really helpful. So the last question that's in the Q&A function is, how do you take part in the trials that have been mentioned this evening?
Oh, this is a good one. Priscilla.
Thanks for the question. So there's different ways in which you can take part. So as I say, sometimes we do have online surveys that you can look up. I always signpost patients to the EXPPECT website. We also have a YouTube channel, and that tells you a little bit more about trials. It could be that you are approached by the clinician looking after you, or the research nurse who may want to have a quick word to see if you'd like to take part. Just keep your eyes peeled on the EXPPECT website, and there's also a website called clinicaltrials.gov. You can go on there, enter, for example, endometriosis and different filters, and that can also tell you about the research that is currently being undertaken. I am more than happy to be approached, and for example, for patients who are in Scotland who might say, oh, I don't know how to get in touch with maybe the nurse in Glasgow, I'm more than happy to make that referral as well. So usually on the website for that trial, it will signpost you to a clinical research nurse or an email that you can get in touch.
Great, thank you. So there's another question popped through. I will respond to some things that are happening in the chat as well. There is another question that's come through about endometriosis, and is it possible that it can cause blocked fallopian tubes? The querent has recently had a laparoscopy and was diagnosed with superficial endometriosis. They also found that the fallopian tubes were blocked.
Lucy, I can answer that bit, or Lucy, do you want to answer that?
I'm very happy. So yes, endometriosis can cause blockage of the fallopian tubes. We quite often see it more in deep endometriosis, but we certainly can observe it in superficial endometriosis. That inflammatory process can cause scarring. I suppose there's also other factors that can contribute to blockage of the tubes. So think factors such as infection can also contribute. I suppose it's important to know about the state of whether or not the tubes are blocked, certainly in terms of planning fertility.
Great, thank you. And there's a specific question in the chat around surgery. So during diagnostic laparoscopy, would endometriosis routinely be removed, and how would this be done? Excision, ablation?
Lucy, do you it fits with your bit of the top.
Yeah, so to go back to when I was talking about particularly what NICE suggests we should do about treatment of superficial endometriosis, I'm going to talk just about superficial endometriosis. They say consider removing it at the same time, and as I said, the evidence that we have says does support doing that, but it is based on really small trials. There isn't any long-term follow-up. We know there's a very high risk of recurrence, but I think if that has been, the role of surgery to improve pain symptoms should be discussed with you when you're being placed on the waiting list for surgery, and the option, if you wish to pursue that, should be offered to you. It has to be caveated by, depending on where the lesions are, it may not be technically possible to remove them at the time of surgery. In terms of that question of excision versus ablation, we don't know the answer. For discomfort with intercourse, there is some evidence that suggests that excision might be better, but actually for all the other pain symptoms, we don't have good evidence to say one's better over the other. I think overall our preference in Edinburgh is we predominantly do excision compared to ablation, but that's based on our local preferences, and we don't have a sort of evidence base to support one over the other. But I think it is something that we really, really need better evidence for, and that's why we're doing the EXPPECT trial, because I think that, I mean, the NICE guidelines are based on 3 trials of 173 women at 6 months. This 12-month data is 69 patients. And for a condition that affects 1 in 10 women, I think having that small an evidence base, along with the uncertainties about the long-term impacts, both making that nerve component of the pain worse, I think there's a real need to try and better understand who surgery will benefit and who surgery won't, so we can make that decision, come to that joint decision making when you're being consented for trials, when you're weighing up the pros and cons, the risks and the benefits.
It was really helpful, thank you. Again, there's a question on pain management and if there's a relationship between diet and pain management at all.
So a good question, and we don't really know the answer to that. And that's one of the reasons why Priscilla mentioned one of the studies that we're doing is looking at the relationship between diet and pain and endometriosis. And hopefully maybe next year you hear from the person who's leading that in the centre about how she's getting on with that, and we may even ask some of you to take part in it. I think though there is anecdotal evidence of people finding that if they take things out of their diet, sometimes their pain symptoms get better, and we'd recommend that people do that carefully and maybe taking one thing out at a time, and also be careful that if they're taking particular foodstuffs out of their diet, they maybe take a good vitamin supplement. So just cautiously remove things and see how you get on. But there are lots of things on the internet that say there's particular diets for endometriosis, but there haven't been any good studies that have supported any one in particular.
That's great, that's helpful, thank you. And so we're running quickly out of time. There is a comment in the chat around someone who's had 23 plus UTIs, which they believe is contributed from hormones being imbalanced. So sorry, I just need to scroll down. And eventually led to sepsis in 2021 and put on antibiotics for 1.5 weeks and have not had a single UTI since. I went from being chronic to be completely fine again. I'm not sure if there's something that anyone would like to comment on. I'm not quite sure what the querent is getting at here, unfortunately.
So I suppose that, again, as we pointed out in the presentation, lots of patients with endometriosis sadly experience urinary symptoms as well, and can have a tendency to experience more urinary tract infections. But it's great if this person responded well to antibiotics. Often people who have recurrent urinary tract infections get put on a daily dose of an antibiotic for a long time, and that's the way to treat it. So hopefully that will have resolved the problem for this person.
Thank you, thanks, it's really helpful. And I think there is some in the chat. There was someone posted a question about acupuncture that was answered by someone else in the that's participating, so that's wonderful.
Yeah, can I just add, so acupuncture isn't generally available on the NHS for endometriosis, but we're lucky in Edinburgh because it's the person who delivers it actually works for the university, so she does it as part of her research.
Right.
She hasn't been working during COVID for personal reasons, but she's planning to reinstate some of her clinics, probably virtually initially. I think, Priscilla, you might know, I think it's starting up in the next couple of weeks. But yeah, I'm sorry we haven't been able to offer it. As I say, we don't have NHS funding for it, so, and it's delivered only by one person, but hopefully be up and running again.